film. Just so many emotions came up, even as a physician, right? I felt the pain that people were going through, and I have to say, I was one of those people who probably inflicted a lot of this on people. I prescribed these medications over the years, and I guess what I'd like to say is, I think this is the paradigm for medicine in which we live. And it's a paradigm that I learned in medical school that was emphasized with my colleagues, was emphasized in journals, was emphasized at symposiums. And this is the medical model in which we live. And I practiced medicine with this model for 20 years. And in that model, I think I was a very good physician. And I prescribed most of the medications that most of the people in the film talked about. And what switched me was understanding or learning about what's called the Adverse Childhood Experience Study, which was published 22 years ago. And I only heard about it 2 years ago. And at the same time, a patient told me about this study, as well as Dr. van der Kolk's book, The Body Keeps the Score. And exactly, yeah. And it just changed the paradigm that I saw human suffering, mental disorders, physical disorders, medical disorders. And it really changed the focus on how I worked with patients. Anyway, I'll stop there. I have a lot to say, but I want to give other people some voices there. Thank you for having me here.
So thanks for being here, Drew. And Chris, would you like to go?
Sure. My name is Chris Page. And first off, I want to thank Lynn and Wendy for making this incredible film and giving me this opportunity to speak about this incredible film, and most importantly, to validate my suffering and the suffering of thousands of other people. Even though I've been a therapist for 27 years, I was severely injured by psychiatric treatment about 6.5 years ago. I truly believe, because my career started in the early 90s when all the medical changes came, all the drugs were being introduced, I think that kind of got me brainwashed into the paradigm. And as Dr. Factor said, there are a lot of things in my career that I look back now with a lot of regret. And I never heard the word trauma in grad school. I taught psychopathology to master's level students for years. I never talked about trauma in there. And I think what the mental health system forgot a long time ago is that we're mammals, and that mammals hurt and mammals get scared. And when mammals hurt and mammals get scared, ironically, we kind of all act the same. And it just means that we're normal human beings going through pain and suffering. And the symptoms that the mental health system has decided are symptoms are actually just hardwired mammalian responses that are designed to get the things we need to heal our trauma, which is connection with other human beings. And that's the irony of this. And Dave Kolk talked about it specifically, is when you lose your empathy, which these drugs cause, the very source of connection to other humans that will heal your trauma is disrupted. And I'm sure I'll have plenty more to say, but why don't I stop there and turn it over to someone else?
Okay, thanks, Chris. Next is Dr. Vieten, or as she's sometimes called, Doc V.
Because no one can deal with the last name. I am humbled to be on this panel because it's sometimes you feel like when you're out there practicing that this is a very lonely journey, and you're the only provider of care that thinks the way this panel has already expressed themselves. So it does me good just to be with kindred spirits. I certainly was raised in the exact same medical model in psychology, and always, no one mentioned in differential diagnosis class that those diagnoses were all made up, that they were constructs. and not medical problems. No one mentioned in psychopharmacology class that everything that was being taught was really models and not actual science, and that the actual state of the arts for pharmacology was to throw crap at the wall and see what sticks. When you stop talking, then, you know, we've won and we can stop prescribing. You know, none of this was ever mentioned. And I know I'm humbled by the fact that I know for a fact that there are people who lost their lives because I made the referral to psychiatry, as I was trained to do. And they went down the hall and got those pills and never came back. Anyway, I'm also the chairman of the board of directors of an organization called the International Society for Ethical Psychology and Psychiatry. And that organization is basically a lot of people who are providers of mental health care professionals that share this paradigm and want to get the word out to other providers about the harms of the medications and the harms of the medical paradigm and the medical model for human suffering.
Thank you so much. And last but not least, we'll hear from Carla Helbert.
Thanks, Nicole. As the others have expressed, I'm so humbled and thankful to be here. In this film, I'm gonna cry. Every time I've seen this movie, it makes me cry. And which is fine, I'm a fan of crying. This is a topic that's really important to me. I work with a lot of people in trauma, lots of kinds of trauma, but mainly the focus of my work is around traumatic bereavement and traumatic death and traumatic grief. And that shifted. I've been a therapist for a long time and worked for a long time with people on the autism spectrum in private schools and with kids and adults with autism and other developmental disabilities. And certainly that population has a lot of trauma. But then in 2006, my son died of a brain tumor and my whole life was changed. And I, you know, like you said, Chris, in grad school, there was not a required trauma course. And I did take a class in counseling and death and dying and grief and bereavement. I was a hospice volunteer. It's been an area of interest to me. But in that semester-long class, they never talked about trauma. There was a lot of talk about models and theory and history of the hospice industry and lots of great stuff, but nothing about trauma. And when it happened to me, it just, my whole world, my universe was shattered. And all the things that I was going through, I didn't know that it was normal. And I started taking a lot of training around grief and trauma, not because I was going to be a grief therapist, but because I was trying to figure this out for myself. And eventually, you know, started leading support groups and going to a lot of support groups. And now I have a private practice and see a lot of people dealing with a lot of child death, but all kinds of death on people who are grieving their loved ones who've died by suicide, homicide, unexpected, sudden deaths, and it's very difficult. And then on top of that, you know, lots of other kinds of trauma as well. And sometimes there's multiple traumas that people are dealing with. And that population is often immediately given antidepressants and benzos and antipsychotics and all sorts of medications. And it's so funny. I'm really happy to be here on this panel with Dr. V too, because when I tell you, when I saw the movie the first time and heard what was coming out of your mouth, I was like, oh my God, that's the exact stuff I say. When I train therapists and when I talk to my clients, the literal same words come out of, I was like, oh, I love this woman. I love this woman. It was so great. I told Angie and Nicole that, but I do a lot of educating with my clients. And like Angie says in the film as well, which she and I talked about, I was super anti-medication, and probably a lot of my colleagues and probably a lot of my clients would also say I still am, but really it's more about being super pro-informed consent. And, you know, so many of the things that are in this film, I hear from my clients. And I've said to myself so many times and to colleagues of mine, it boggles my mind how doctors don't know this. How do I know this stuff and psychiatrists don't know it? And it's just such a difficult place. Like you said, Mary, it's like how you feel really alone a lot of times as a practitioner who has these kinds of ways of thinking and working with people. Spend a lot of time validating and educating people a lot and just trying to support them. And I have clients who are on medicine. I have clients who are on a lot of medicine. I have clients who decide to start taking medicine, and I do try to hold their hand through that and be with them as much as I can and provide as much education and help and assistance as I can. And usually they start coming off, and then I'm there for them when that starts happening too. So this film is so important, and I wish every therapist and every doctor could see it, and all of my clients too. It's such an important message, and I'm so grateful that it's out here.
Thank you, Carla. So I think because we want to focus a lot on trauma in this post-screening discussion, we'll start with some questions around that, and then we'll move to the audience questions. So first, I'll pose this question to Chris, but other panelists can certainly jump in if you have things to add. So being someone who was a therapist, but also a member of the prescribed harm community yourself, meaning you took psychiatric medications and you were harmed by them. Can you share a little bit about your own experience with the medication, and then talk about, is the harm that is caused from psychiatric medication also trauma, and how so?
Well, first off, my story real quick is I had come from a history of complex trauma myself. And of course, because of my age, no therapist or any doctor I ever spoke to along my own personal journey ever said, you have trauma. And I remember I had just gotten divorced and was super stressed and was working with a colleague. And they said, you look really super stressed. This is Klonopin. Take half of this and you'll feel relief. And I took it, and within 10 minutes, I wondered, where had this been in my life? I mean, it had literally taken away all the anxiety. And then I started taking it regularly. And then about a year and a half later, I started noticing my impeccable memory going away. And started doing a little research and found the Ashton manual and tapered off. But was off for some years, and then life stress came back again. And because I didn't know anything about kindling and other concepts that we could talk about, intolerance and things like that, I took the grand total of 16 total milligrams of Klonopin over 3.5 months and got dependent again, and immediately went into a tolerance situation where the medicine was causing me to not sleep. And then I foolishly put myself into a medical detox where they took me off 1.25 milligrams of Klonopin in 5 days. I went completely insane, ended up in a psychiatric ward 2 days after that. Spent the next 4 years pacing 13 to 15 hours a day, considering suicide every moment of those 3 years. So trauma, yeah. But what I really realized is trauma's the problem, and then trauma's the outcome. And because trauma creates anxiety and all of the mimicking things that we've labeled as mental illnesses, and then you get on the meds, which then traumatize you further. And then your entire social system turns on you because they don't believe it's the meds, they believe it's you, and and if you come from a trauma history, you probably have also been told your word is meaningless and your story is meaningless, and now all of a sudden it's being told to you again. And that is incredibly traumatizing. And I think the #1 cause of suicide for people after the acute phase of being adversely affected by these drugs is the social support system, or the lack thereof, or even worse, what I see a lot is the social system actually, I would call it actively plotting the murder of their loved one, because they're so misinformed, that they will intentionally turn everyone against you, because they're operating often from an addiction paradigm don't enable this person. But think of the absurdity if you had a compound fracture on the ground and you were bleeding and your social support system was standing around you going, don't help him, don't help him, don't help him. And that's what happens to an enormous amount of people that go through this. But the one thing that I would say to anyone out there going through this as a really optimistic thought is I do not believe when you heal from this that you are left with trauma. Okay, no one relives withdrawal when they get through it. You feel so much better that you won't relive it. You will probably have some things you need to repair in your life relationship-wise, but I don't think from a trauma definition, there will be no reliving of this. So once you get through it, you will be through to the other side.
This question is for Drew. You mentioned that you just learned about ACEs recently or a couple of years ago. For anybody in the audience who doesn't know what ACEs is, can you explain that? And then also talk about how your colleagues responded when you went to them with this new concept that you've learned about, and how, as an internist, how learning about ACEs changed your way of thinking or your way of practicing.
Yeah, thanks, Nicole. So anyone who doesn't know, ACEs stands for Adverse Childhood Experiences, and is based on research that was done in the 1990s in a collaboration between Kaiser Permanente in San Diego, over 17,000 patients, and the Centers for Disease Control. And it was published in 1998. And briefly, the ACEs are in three main categories. It looked at emotional neglect and abuse, physical neglect, not touching, abuse, sexual abuse, and then household dysfunction. Someone in the household who had mental illness, someone who abused drugs, divorce, things like that. So basically, those 10 topics. And the beauty of this study was that the more a person had of that in their childhood before 18 years of age, the more medical illness they had. Heart disease, COPD, chronic obstructive pulmonary disease, even cancer, and not to mention depression and suicide. And so it was this model of, as Chris says, and as Dr. Kolk said, it's sort of our body's reaction to stress and how we dealt with stress as a child. And it was an aha moment to me. I've said in talks I've given, most physicians don't know the cause of high blood pressure, autoimmune disease, neurologic diseases such as Parkinson's, multiple sclerosis, or Alzheimer's. We just say they just form. And if you don't have a good understanding of where they come from, you're really giving medication to placate the symptoms, which is what we saw in this film, right? We're just placating insomnia that Shalimar saw from working at nights, right? So we're placating symptoms. So if we don't really treat the trauma that people had as a child, and the medical society in general doesn't know effective ways, but I'm losing my thought here. But so when I saw that there's a new paradigm for understanding disease processes, then there's a different way of treating it. And so I had these deep discussions with people, screening for adverse childhood experiences and talking about what crap they went through as a child and whether I directly helped them, but they felt heard and they felt seen and they had stories to tell. And what Dr. Felliti from Kaiser said is just the act of having someone tell their story and someone non-judgmentally listening and hearing it is part of the healing process. Yeah. And when I talked to my colleagues, they said, well, what do you do? Like, they didn't get it. And I understand they didn't get it because we were, and I'm going to use this term, we were brainwashed in this medical model of disease process and cure. And so I'm not going to be able to tell them there's a new world out there, a new paradigm. So people like Dr. Kolk and many, many, many other people, Mary, even though we feel alone, there are many people who are trying to spread this word, are trying to spread this word of a different paradigm for treating mental illness, substance abuse, and even cancer. And I just wanted to point one thing here. I just was looking at my table here. This is a Time article from, I can't read this. Anyway, a few years ago, the Alzheimer's pill, right? Here's another breakthrough pill to treat Alzheimer's. Well, Alzheimer's and dementia is a stress response. I believe it's a stress response. And I think until we really realize that, we're going to see more and more Alzheimer's, we're going to see more and more cancers and heart disease. I apologize for taking the stage. I just want to show this one. I came across this book. It's called The Stress of Life. And this was written in the 1950s. And he basically, Dr. Hans Selye, who was an endocrinologist, basically said, as all on the panel know, we're just dealing with the stresses of life and we're seeing the outcomes of the stresses, right? And as Dr. Lemke said, we vilify, in the movie, we vilify pain, we vilify everything.
Yep.
And if we don't really get to the underlying causes of this, we're really just placating mental illness and physical illness as well. And I've actually seen many, many people start to understand this. And when they start to understand this, they start to take control of things and they don't depend upon medication to treat the symptoms, whether it's psychological symptoms or the symptoms of high blood pressure or the symptoms of diabetes. I have a lot to say, but I'll let other people join in here.
So, am I muted? No.
No, we can hear you.
Nope.
We hear you.
Dr. Vieten, you said in the movie that PTSD is a problem, but it's not a mental illness. Can you expand a little bit on what you mean by that?
Yeah, what I always want to make sure people understand is that the trauma is real, and I would never want someone to think that I don't believe in their trauma. You know, I've deployed twice myself. I've seen some of the things that can happen, and it's a lot of on-the-job training in trauma just to do that kind of work that the military has you do. But the thing is that the way that I explain it to my warfighters is that we have to be fit for full duty, which means completely and totally mentally and physically well in order to deploy. And it's ironic, I get that in order to be a target in a war, you have to have a perfect body, but that's how we roll. So, but you deploy fit for full duty, and then you come back and then they tell you you're mentally ill. And so I say, no one has ever deployed fit for full duty and returned mentally ill. It's an absurd paradigm, and it's a money-making paradigm mostly. But what Chris said is exactly right. Your body, when you come back, is doing all the things that it is meant to do. All the barometers of your well-being are firing off and telling you that something's not right, not so that you'll run to the doctor and get a diagnosis and a pill, but so that you will attend to your mind and your body and attend to those things that are not right. So that's what I meant by that, is not that there's no problem. There's a significant problem, but no amount of labeling it, with mental illness labels, and no amount of drugging it is going to have any positive effect whatsoever.
Mm-hmm. Yeah, and that's the thing I talk about with clients a lot, is that it's not a disorder. It's what's happening is normal. The situation might be messed up and disordered, but you are responding in a completely normal way. That this is what happens. A post-traumatic stress is very real, and education, I have found with clients, of explaining to them how the brain and the body respond and why. And it gives them a lot of power and makes them feel like they can understand now, okay, my body and my brain, my nervous system really are trying to protect me. Post-traumatic stress makes total sense. I mean, you've had a trauma, it's in the past, and now you're here post that trauma, and you're still experiencing this major stress reaction. And I try to help people change their language around things too. Instead of talking about my anxiety, I get them to talk about fear. It's fear. You're having a stress response, or you're afraid of something, whether that cue is outside or inside, whether it's a memory or an intrusive thought, you know, however you explain. I like to explain what those things mean to people so they understand what's happening, and then teaching them ways of calming their body down so they have, you know, some space to be able to process what's happening, practice compassion with themselves, and use any kind of skills that we're working on to help them get through that moment. And what I've found is the more that they learn that they can get through these really difficult moments of stress and fear, then they learn to trust themselves in it. And that's so important. And also that telling the story, that non-judgmental hearing of somebody's story, no matter how many times they need to say it. I mean, that's the narrative therapy, telling your story over and over and all the different aspects of it, and learning how to integrate that. And that's so powerful and healing. Dr. Beaton said that in the film to Angie. It's post-traumatic stress. It's normal. You know, you've had all these losses, you have all these griefs, and pointing out to her all these things that you have lost. Why would you not be having these responses? Normalizing those reactions for people, I think, is so important, rather than, oh, you're crazy, you have a mental illness, it's a disorder, when really it's very adaptive. It's difficult, super scary and inconvenient too, but it's also normal.
And just to piggyback real quick, I mean, that's been an evolution for me professionally. Is now the primary focus in my work is, are you safe?
Mm-hmm.
Because until a mammal is safe, how many times have you been anxious about something and you can't find your keys, or you can't forget something? Well, because when you're anxious, the part of your brain that you want to use, the thoughtful part of your brain, the intelligent part of your brain, goes to sleep.
Mm-hmm.
And so one of the things that I tell my clients too, besides let's work on being safe, is use my nervous system to plug in.
Mm-hmm.
Plug into me, I'm calm, let me regulate you down to where I am.
Mm-hmm.
And I think that's the key. The other thing I've learned, and this is an evolution too, and even specific to trauma work, I'm starting to see finally an evolution with this, is when I got trained in EMDR, eye movement desensitization and reprocessing 17 years ago, the model was kind of push through trauma. You know, you feel it and push through it. And what I started to see was a lot of people getting re-traumatized by trauma treatment. And one of the things that I've learned at this point in my career is slow, slow, slow. And if you think you're going slow enough, then go slower.
Mm-hmm.
Because we basically are propping up an injured nervous system. And until we have something else to put it underneath, we can't pull the rug out yet.
Yep.
And I think that feeling safe is the crucial part of all of this.
Yes.
And that's why the meds, again, can be so damaging, is that disconnect us from that very feeling of safety. And disconnect us from our tribe, from our pack, you know, from the people, our community behind us that keeps us feel connected and safe. We are social animals. We need connection to heal.
Mm-hmm.
And that's my piece there.
So this is from the audience. I'm looking for advice as a young psychiatrist wanting to learn how to have these conversations. Finding patients often frustrated by my discussions about deprescribing and encouragement of non-pharmacological management of daily stressors.
Go ahead.
Yeah, I just wanted to say that that one of the things that I do find that for everyone, bringing this up to them, especially if they've already been medicated and they put so much of their investment into the mental illness label and what it does for them, and it does do things for people, but no matter what you think of it, it's helping them or it's serving a purpose in their life. And then the medication as well. So one of the things that I do with my clients is provide them at my expense. I don't ask them to go out and buy it because I don't believe in that, sort of, everyone's going to become needy if you help them a little. But at my expense, I provide each person who comes in on medication with a copy of Bregan and Cohen's book, Your Drug May Be Your Problem. And I just say, hey, just take this home, give it a read. Let me mark some pages in here so you don't have to read the whole thing if you don't want to. And because no one is, pointing the finger and saying you, they can sit back and in a very undefended way absorb that information. And inevitably they come back to the next session saying, I get it. I need to not do this. So super valuable tool.
I mean, for me, go ahead.
Oh, I was going to say, as Chris was saying, the last thing a patient wants to be is feeling unsafe. And for some of them, being on a medication is safety.
That's true.
And so, as a physician, this happened in the opioid crisis, right? And the mess that was created. And, anyway, so for some people, patients, taking their medication away is a safety issue.
Mm-hmm.
And so understanding, as Dr. Vitin said, understanding the potential causes for emotional disconnect with the medication, saying, I'm not going to take this away from you unless you're ready to do it.
Mm-hmm.
But we need to understand why you got here in the first place. Mm-hmm. And then, I always use the term, these medications are safety nets. Now, obviously the documentary brings up a lot worse issues than safety nets, safety nets with spikes perhaps. But, when you feel ready, maybe we can kind of lower the safety net a bit when and make sure you feel safe.
I mean, the other thing I was going to say, kind of back to the question, was that when I worked with kids, the parents would get such a sense of relief when you'd give them a medical diagnosis. And because it kind of absolved them from any of their poor parenting. But the reality is the way I've shifted that paradigm is, okay, you don't have that diagnosis. And here's the good news, is you're not going to be sick the rest of your life either. Because you don't actually have this diagnosis, we can heal this. And you won't have to take these meds for the rest of your life. And you won't have to deal, hopefully, with some of these issues and problems for the rest of your life. But we're going to do specific trauma-based stuff and connectedness and not medication. And that's how we're going to get you to your goal. I mean, that's how I would maybe phrase it or frame it.
So I just wanted to add to what Drew said. What he's right about that safety net. And one of the problems with prescribing is that it's, here's your pills, take them for 30 days. And if that doesn't work out for you, go to the emergency room. I don't have a filter, so I just say these, I call them like I see them. But so one of the things that I do is just when I know someone is going to be withdrawing from medication is, I walk the walk with them. I never say things like, go to the emergency room if this isn't going to work out. It's, here's my phone number, use it. How about if we meet twice a week until we see how this is going to roll out for you? Do you need a mentor? Would you like me to hook you up with someone who's already been on this journey with a similar drug? And what would that look like? And, so I just really go the extra mile to build that, to put in a different kind of net and probably a more efficient net. And I will also say that, I really am emphatic with them about the illusion that there is some sort of a safety net, because those drugs are dangerous. Mm-hmm. And you're far more likely to commit suicide on a psychiatric medication than off of it when they control for the other variables. So how is this safe? How is this serving whatever purpose you're taking it for,
And then, on that same line, as Chris said earlier too, going really slowly with that. I never just like pounce on somebody with how bad the medicine is. I pay attention to what they're taking. And then, when things come up naturally, like I have, a 19-year-old who was on Zoloft who I've worked with for a long time, and she decided to start taking it and was having really bad side effects and was coming off. and was experiencing a lot of the disconnect with empathy with others. And she really noticed that. And I said, well, that's part of the medicine too. And just helping her to see how it's affecting her, and then supporting her and being able, because she's so scared of the anxiety, which really is connected to a trauma, a major trauma that happened a few years ago. And being with her, helping to create that safe space, but doing it all really slowly, because you can't just push somebody into, and I would never push somebody into coming off their meds. I mean, that is the most dangerous time is when you go on a medicine or you change a dose or you come off. And I tell them that as well. And like you said, Dr. Veaton, all my clients have my phone. They all know they can text me. They all know they can reach me. Nobody ever abuses it. And they only contact me when they really need it. And to know that there's, like you said, this extra kind of safety net is really important. I'll talk to their psychiatrists or their prescribers, and I want to, because I want there to be a plan. If you're going to either go on meds or you're going to start coming off, we need a good plan to make sure that you are safe. So that's so important.
There's a comment that was made that someone in the audience said, my safety net on meds needed to be 2 weeks, not nearly 7 years. Can anyone speak to that short-term, the nature of medications and this safety net, using them for short-term use versus this, like once people are put on them, it seems to be, there's no exit plan. It's like a ticket to a decade of being medicated.
I'll just throw into that you are far more likely to commit suicide on an SSRI in the first 90 days than at any other time. So this idea that somehow they're good for short term, it should have a great big asterisk after it, because and again, I'm just a person who in my practice I have never seen the person for whom psychiatric medications were the best or the only alternative. I haven't met that person. And I certainly haven't met the person who needed them in the sense that like they couldn't get through their trauma or participate in therapy another way. I haven't met that person yet.
Mm-hmm.
The thing that I see as a physician is that I don't think our medical society knows how to help people in a way that's, or even have access to that help in a way that's meaningful. And so as a physician, you want to, I wanted to be the person who saved the person, saved the day. And, and it is easy for me. It's easy for the patient to be given medicine. If we had a different structure for helping someone as opposed to reaching to a pill, I think a lot of this could be avoided. I just want to say, I was on Zoloft and Paxil and citalopram for decades, and I don't think I was what was called traumatized, but I was raised by two wonderful parents who really didn't know how to feel emotions with me. And I'm sure Chris and Carla know about attachment disorders. I didn't, probably get the attachment that I really needed. So, but I was able to, I got off my Zoloft last year after I understood that my father was the way he was towards me because he didn't grow up with a mother. I stopped hating my father for being an asshole to me. Did I say that? But because he was who he was, because he wasn't raised by a mom. And so, when I understood his story, I understood that he couldn't have been the father that I needed. And that kind of calmed my own. I had a Chris Page next to me. My nervous system was calmed down. And I said, I don't think I need Zoloft anymore. And I've hit some bumps in the road, but I'm working on it. And I think, for all of us, that's sort of the support that most of us need. Like, who was it? It was Angie. Like, I just needed to be told that this was happening. I didn't need to be on all these medications.
that's what I just makes me so breaks my heart so, because it's not like it's hard to give space to people to tell their stories. And it's
But I
that.
think we're not taught how to do it.
Well, you're right, Chris.
You know?
So this is interesting. Something that we talk about at Warfighter Advance all the time is this, how people are literally dog whistle trained, that as soon as someone, whether they're your friend or your relative or your coworker, starts to say something hard, we are dog whistle trained to say you should go talk to someone.
Yep.
And that is code for you need a psychiatrist and you probably need pills. And the whole culture is doing this. And so one of the things that I literally yell at these guys during the week, because I'm not a friendly person, is, you know, when somebody sits down, they self-select them into your presence and begin to tell their story. How dare you tell them that they should go talk to someone?
Oh, yeah.
Because they are talking to
They
someone.
are talking to
They're
someone.
talking to you, you know, and how dare you? So just shut up. You don't have to actually answer, and nod and provide them with, we teach the core conditions. So empathy, genuineness, unconditional positive regard. Just nod and be empathetic and genuine, but don't tell them to go talk to someone.
Yeah.
This is the most absurd thing, but you can see the effect of that psychiatric marketing, because everybody does it.
Mhm.
Everybody does it, just across the board. As soon as you begin to talk about your own pain or your own suffering.
Well, it comes back to what you said in the film about discomfort, that this culture is conditioned to think that any amount of discomfort is abnormal.
Yeah.
And that if you feel discomfort, then that needs to be fixed. And not even just to be comfortable, but to be happy. And if you're not happy, you better figure out how to get happy real quick. And that's not normal. You know, when you've gone through trauma, when somebody who is so important to your life has died in a traumatic way, when any of those things happen, it's not normal to just be like, oh, well, I can just choose happiness.
Right.
It's so, and then for people, but the reason that people say that, I mean, I was really angry for a while. Even all my therapist friends said to me after my son died, do you think you need to go talk to somebody? Right, you're right. I was talking to you, you know. Support groups were huge for me. And I did not go to a therapist because I was afraid. And because I know how this goes, I was afraid that somebody would tell me to move on, to find closure, to make me give up my grief and all the feelings that came with it. And I knew that I would be really angry, and I didn't think that would be helpful. Now, it's not true. I want to be clear. It's not true that you have to have experienced the death of a child to help a person who has experienced that, or even a traumatic death at all to help somebody. What it takes is being able to be comfortable in your own discomfort and having that non-judgmental, listening, compassionate space. You can't fix people. You can't fix their trauma, and you can't fix their grief and pain. And it doesn't need to be fixed. The trauma can be healed. Grief doesn't even need to be healed. It's a normal reaction to loss. It's a thing we learn to carry. It's integrated into who we are, and it changes us, and as trauma does. You know, there are pieces that can be healed, and then there's pieces that we learn to carry. And we can only do that when we have the appropriate support around us. Otherwise, we can't grow and develop in our own discomfort and pain. And our culture, sadly, has very few places where we can learn how to do that.
And I was just going to piggyback on the comfort idea again, is that's been the biggest shift in my life. Is when I was a kid, none of my friends' parents were terribly worried if their child was comfortable per se. Okay. Now today we have an entire generation of parents that protect their children from frustration.
Mm.
Mm-hmm.
And frustration is the thing that gets us to motivate to change. And by protecting them from frustration, which they see as uncomfortable, then we have an entire generation of kids that are horribly anxious and depressed because they don't think they can do anything on their own.
Yeah, that's true.
You know, so it's so American. We're so good at the comfort, but not good at comforting each other.
Right.
So speaking to this, I guess, Carla, what you just said about, you know, not being able to fix someone, and Drew, you saying, you know, that it's so easy to give a medication, but there, or maybe Dr. V, you said this too, that you've never met somebody who there was like not an alternative that they could choose instead of medication first. So we have some people asking, do you feel like neurofeedback is helpful for PTSD, ADHD, or psychological issues? And someone else asked about EMDR. Are these helpful tools, or are they just ways to, fix people of these issues that we're talking about?
So at Warfighter, we have a concept of this. If you've seen one warfighter, you've seen one warfighter, and I think that's true of human beings. And so a lot of what happens with psychiatry is it's incredibly reductionistic. And it's kind of like you have a strep throat, you prescribe this antibiotic. And so if somebody comes in and says, I can't sleep, you give them this pill. Doctors are pretty good at not asking the why question, because if they ask the why question, their 8-minute time frame is now blown and they can't move on to the next person. So they stick with this symptom thing. But the reason I'm saying that is because just like there's not there just isn't one solution. And so what we ask our warfighters to do when they go through our program is to build up this smorgasbord of possibilities, of things that they could use, could try, knowing that, when you go to the Golden Corral, you have this huge smorgasbord. You don't have to eat everything on it to get full. But you do, it's good to have a lot of options and a lot of things to choose from. And so what we have them do is look at things like neurofeedback and the alpha stem and the healthy wave mat for pain and all these different things that are out there. And we ask them, use your critical thinking and weigh the risk benefit. No one has ever in the history of the world died of anxiety, but they die of anxiety medications every single day. So the risk benefit ratio makes 0 sense. But who's died of neurofeedback? Nobody, but lots of people benefit from it and it's harmless. Yeah. So why not try it? Put it on the smorgasbord. Yeah. So, and some people just don't like it. And some people really think it's great. So, but first start with risk benefit. Mm-hmm. And if it passes that hurdle and it appeals to you, give it a try. But I find, for example, neurofeedback is very helpful for some people. I find that, like I said, the alpha stem, very helpful for some people and harmless. So, but that's really the important thing, is to look at the risks. What are the risks of starting an exercise program? Very small for most people. What are the possible benefits? Well, reduction in anxiety, a better mood, sleeping at night, eating better foods, improves your sex life. Like, what could go wrong, So exercise is a wonder drug. Put it on the smorgasbord. Mm-hmm.
And I'll just jump in again. As someone that's done EMDR for 20 years, I find it incredibly effective. But like any technique, it's like a scalpel, and it's only as effective as the surgeon that's wielding the scalpel. And so you need to make sure, whoever you're working with, that you're feeling better and safer and not more agitated and dysregulated. Yes. Other thing that I would suggest, if somebody is looking at trauma treatment, is something called the Safe and Sound Protocol that was developed by Stephen Porges, who developed the polyvagal theory. And it's a 5-day listening program that I'm learning now. I'm going to make into a 50-day listening program because I want to go as slow as possible. But basically it reconditions the inner ear muscle so that we predominantly only hear high frequencies again, which are social engagement frequencies. When people have trauma, and I guarantee anybody out there that has had any trauma history, a lot of your trauma is probably triggered by auditory sounds. Okay? And when that filter starts to get disrupted, which for all of us it does if we've been exposed to trauma, we start hearing a lot more lower frequencies, which are the predator frequencies in nature. And so that, like the sound, like what ADHD kids always say, oh, it's the fan. I can't stop thinking, hearing the fan, or I can't, the hum of the AC. Well, that's a low frequency, and their brain is going, that's a threat. So am I going to worry about the threat or math? I'm going to worry about the threat. And so these are ways to re-heal our nervous system and reset it. I always say, I want to reset your nervous system to factory settings. The way you were born into this world, I want to reset your nervous system to where that was. And so just some other ideas on ways to handle trauma.
Yeah, and as Dr. van der Kolk book title said, the body keeps a score that, emotions lay within the body. And, I think one of the ways I think Dr. van der Kolk said that there's more efficacy for treating PTSD with yoga than there is for medication.
Right.
And, it doesn't have to be yoga, but any sort of movement, just getting up out of the couch and moving into a different room, going for a walk, just doing stretching. Pat Ogden, who invented Hakomi therapy, said, you can't feel remorse when you're upright and your arms are out, so just getting your body into a position of emotion that you want to get into. So really moving the body. And the other thing I just want to say is there are a lot of great therapies, EMDR, brain spotting, tapping, emotional freedom technique. The problem is availability and cost. And I think a lot of people, including myself, are looking at ways to make this available, especially during COVID times, and make it both available and accessible economically, because I think we're all traumatized. We're all traumatized and we all need our own healing.
Yeah, I would like it, that availability always makes me cringe, because there's always a gatekeeper that forces you to have a psychiatric diagnosis to access it. And that is something that has to stop, that you have to capitulate and you have to accept that you are mentally ill in order to get these therapies or to get to that level to access that therapist. I mean, there should just be an ICD-10 code for help.
Yeah.
Helping and just forget about, the whole diagnostic and statistics manual just needs to be burned and thrown away.
Amen.
I do not, I don't allow my clients to use those labels. In fact, I don't even call them clients in the real world. I call them people, because they are people. And
we all have the same diagnosis. We're human.
yeah, absolutely. But and I won't let them refer to their children as autistic or ADHD. I say you need to refer to your child by their name, and accept your child the way they are. And because there's just no medical efficacy for any of that stuff.
Nope.
And so why you have to, why the label is necessary to get to, why can't you have neurofeedback without being ADHD? Why can't you have neurofeedback? Because you need to calm down.
Yeah. Yeah, and I'm a yoga teacher and a yoga therapist. And I will say too, one of the reasons why yoga is so helpful is that it's meant to calm the nervous system. In the tradition of yoga, asana, so the poses that move the body around, that's just the third limb in yoga. And it moves up to a state of meditation where your nervous system is going to be in a calm space. And that's what, and breath work is in between there, pranayama. And so it helps to calm your nervous system. Although there are like plenty of types of yogas that are stimulating. And so you want to make sure that you're working with somebody who knows the difference, because pranayama, for example, so the breathing techniques, there are specific yoga breathing techniques that will stimulate the nervous system. And that's not what you want. Like whatever kind of thing you're working with, you want to work with trauma, where we're talking about trauma. You want to calm the nervous system down and stimulate that parasympathetic response, that rest and relax response, in the sense of safety. Like you said earlier, Chris, I'm not an EMDR trained therapist. I'm trained in eye movement integration, and I'm trained in hypnosis and lots of stuff. When people really want EMDR, I have people I send them to because I know that those people are going to create a safe space. It's all about the safety. And if you're looking for a yoga class, one thing that is good, I know we're all sick of Zoom yoga classes, but, I did a yoga workshop a couple of weeks ago, and I had people there from Germany and from, somebody was from in West Africa. There are people I'm in Richmond, Virginia. We had people from all over. There were like 3 people who were here, and everybody else was all over the world, somebody in the UK. So that's a good thing. You have so much choice. Look for a trauma sensitive yoga class, because the person teaching that class has had, hopefully they're not just saying it's trauma sensitive, hopefully they've had some training and what that means and creating a safe space and a container for people who've had trauma. If you know the teacher and you've already gone and you know you feel safe there, that's awesome too. But again, you know, just moving your body around, dance classes can be really helpful just to help move the energy. You know, our energy, trauma and anxiety, these things are also energy in our bodies. And when you can learn how to help that energy move and flow, then it helps. Our emotions are meant to flow. It's that word emotion is from a Latin verb, emovere, which means to move. They're meant to move. And when we can engage in literal movement, it can help us allow those feelings to just like flow. And I work on that a lot with people, whether we do it in a session or whether, you know, we're talking about things they can do outside of when they're working with me. It's really important to engage all the layers of who we are, physical, mental, emotional, spiritual, because trauma impacts us on all of those levels.
So someone wants to know that with us acknowledging trauma as being so important, are you worried that medicine will like co-opt the word? So basically saying like, well, you know, trauma is the new mental illness. They can say, yes, well, trauma caused your quote unquote physical imbalance, or we start screening children and people for ACEs, for example, and saying like, well, now let's medicate you preventatively because we've asked you these questions and identified this issue. Do you think that we're at risk of that happening? And if so, how do we move away from that, or what do we do?
Is there money involved?
Yeah.
So we're already there. That's why all of those screening tools exist and are in waiting rooms so that you'll pick them up and you'll diagnose yourself and take it with you into the physician's office and, you know, and end up with post-traumatic stress disorder or bipolar disorder or depressive disorder, NOS or whatever it is. But we're already there. The psychiatric or the pharmaceutical industry provides those things. They are in the lobbies, they are in the magazines, they are online. So the screening for, you know, I don't think screening for mental illness should even be a thing, because it really is just a trap for maximum medicating.
Yeah.
But it's, you know, as far as the question, you know, is this going to become the next thing? We're already there.
I know here in California, there's a big push to screen everyone for adverse childhood experiences. And there are people on both sides of the field thinking, you know, yes, we should be screening, or no, we shouldn't. Labeling someone who's had adverse childhood experiences, labeling them as traumatized is traumatizing, right. You know, so the word trauma is traumatizing. But I think we have to sort of talk about, you know, as Dr. Beaton said, you know, the reality of this is that we're already there, we're already here, and we need to just kind of think about how to approach this in a different way and wean ourselves off of the medical model, because it's caused so much harm. And the other thing it does is, you know, someone is labeled as, you know, who's mentally fit, but a diabetic. It takes the agency away from someone, you know, like, no, I'm faulty because I'm a diabetic, as opposed to really understanding what drives someone to not want to exercise, or the stress response and increasing cortisol levels. It can be all explained by physiology. And the more education that we do, the more I think we're going to be empowered to make healthy changes and physiologic changes as well. But there's so many forces out there, not to even mention the pharmaceutical industry, that we're pushing against. So we need to, it's a ground, you know, a grassroots movement here, folks.
And I was just going to say, unfortunately, the two most dangerous words that I'm discovering now are becoming trauma informed. We have a ton of people saying they're trauma informed that know nothing about trauma. that you'll go to them and they'll say, yeah, you did have a lot of trauma and that's what caused your major depressive episode. Or yes, you do have a lot of trauma and that's what created your panic disorder. And they still go back to the default. So as a quick guide to anybody out there looking for a therapist, if they say they're trauma informed and they give you a diagnosis in the first session, run. Okay, because they are clearly not trauma informed.
Although also know that you cannot escape the diagnosis.
Right, for
they,
billing.
They submitted it for billing and now it's yours.
And that's why they all get adjustment disorders.
That's why I don't take insurance.
That's, you know, and I'm not gonna, you know, but when I did, it's all adjustment disorders, because I had an excellent supervisor early in my career say to me in 1992, don't give anybody a real diagnosis because it goes with them for the rest of their lives.
That's right.
Yep.
Give them the most benign diagnosis to access the treatment.
That's right.
Outside of that, do not give them a label that will carry with them for the next 60 years of their life.
So write this down. F4320 is your friend.
What is that for those of us who don't know?
That's got to be an ICD-9 code or an ICD.
It's the ICD-10 code for unspecified adjustment.
Yeah, there we go.
So it doesn't even have an emotion attached to it.
It doesn't even have anything attached to it.
Nope, nothing. F4320 is your friend.
So I'm aware of the time. I think we'll probably just ask one more question and then we can have some closing thoughts, although I'm sad about that because I could sit and talk with you guys for, I'm sure, at least another hour. And we have tons of awesome, interesting questions still that we didn't get to. Do any of you know if the United States is alone in treating trauma with medications like we do and dealing with trauma in this way? Or have you done any research into if other countries have better ways to treat and address trauma?
I would recommend that that people look at Robert Whitaker's work, because he does a lot of synthesizing World Health Organization information. But I will tell you that we have worked very hard as a country to export our crap to the English-speaking world, at least. And I know worked very, very hard to export it to Japan and to make sure that, you know, in wherever we can, that the maximum number of people are diagnosed and treated with psychiatric medications. The sensible stuff and the non-medical model is more alive and well in other parts of the world. And we can learn a lot from them. And that's why some of the most basic things are brought up in Whitaker's book, because a lot of other countries treat psychotic disorders in particular as trauma and stress, and they have better outcomes than we do, exponentially better outcomes than we do. And he goes over that research. It's brilliant.
Yeah, Anatomy of an Epidemic.
The Anatomy of an Epidemic. Yep.
Yeah, I give that book to my clients too.
It's exceptional.
Yes.
I mean, it's easier to be viewed as a shaman and a seer of visions than it is as a schizophrenic. You know, but it's the exact same thing.
Right.
And I think
we say that's not true.
Well, the other thing I think we don't take into consideration enough in the entire mental health field too is the idea of it's trauma and the neurodivergence. We aren't all wired the same. We all have unique neurology that makes us who we are. And so you give 100 people the same experience, you're going to get 100 different nervous system outcomes because that person's nervous system is specific to them.
Yeah.
And we're trying to take every human being and cram them into the same normal, healthy, happy box.
Yeah, the balanced brain.
And it doesn't work because we're all different.
Yeah.
I think, you know, the question goes to sort of what's called Western medicine, and we can say it has its roots here or in Europe, you know. And I think if we all look to, you know, indigenous cultures and see how they viewed, you know, they didn't view it as mental illness, right? Or they didn't view it, you know, so the labeling and the treatment is completely different. You know, I was just reading a book recently who talked about Hippocrates, who, lived 2,500 years ago. And his view is that there's this natural medication or healing process of the body. We cut ourselves, it heals naturally. We don't need to take a pill for that. And we've gotten so far in the 2,500 years since Hippocrates formed sort of modern medicine, we've gotten away from that idea. And there's a lot of work to look at indigenous cultures, indigenous rituals, which may not resonate with those things, but we have a lot of learning to do. Yeah.
Thank you, everybody. So I think we are going to wrap the discussion. But first, I want to provide each panelist a few minutes for closing thoughts. And if you want to tell the audience more about your work or your websites or where they can find you. And then I'll just close out with a little bit about the film and we'll say goodbye. So whoever wants to go first.
Oh,
I guess I'll leave.
If it's okay, I want to jump in just because I'm hitting a very hard deadline. So I'm gonna say hello, say goodbye, and exit. Warfighter Advance's website, it's www.warfighteradvance.org. Our program is absolutely door-to-door free anywhere in the country to any warfighter. We would love to hear from you. So, and I really appreciate the opportunity, and I do have to duck out. Thank you, everybody.
Thank you
for joining us.
I'll go next. I don't have a website. If anyone feels and they want to contact me personally, my email address is drewfactor@me.com. Physician, I've tried to change other physicians' thoughts, and we're stuck in a different paradigm. And I think the only real way to do this is to engage in people in discussions and have engage people in discussions so that they can see a different way of thinking or be inquisitive about this. And so, I tell people, when you go to your doctor, fighting back may make you feel good, but it's not going to help with the relationship. So it's like, do you think that there's any possibility that my medication can be causing my symptoms? Because I didn't have any of these symptoms before I got on medication. And do you think there may be a cause to my symptoms besides, like, what caused my insomnia in the first place? And really have a conversation, inquisitive conversation, because I think physicians need to be enlightened. And I think they're part of the problem. We've been indoctrinated in a web that doesn't serve us ultimately very well. It helps to some degree. And thank you for having me here. I've enjoyed it.
Thanks, Drew. Thanks for being here.
I guess I'll go real quick. As you can tell, I'm passionate about this. If you'd like to connect with me and learn more about what I can offer, you can go to chrispagelcsw.com. Would welcome that opportunity. Just another quick thought. I wish every kindergartner on their first day of school would come home and say, "Mommy, I played with blocks and I learned where my amygdala is, and it's my smoke alarm and it keeps me safe." How cool is that, Mommy, that I have a smoke alarm that keeps me safe? And if we taught kids that, they wouldn't end up in my office when they were 20.
That's true.
So just a quick personal opinion on some things I think we need to look at. And again, thank you so much to the Medicating Normal team for this opportunity.
Thank you, Chris.
Carla?
Yeah, and if you want to get in touch with me, my website is just www.carlahelbert.com. And I think here's one. Oh, here's the books are here because I did this workshop the other day. That the chakras in grief and trauma and yoga for grief and loss are my books. I also have a book for kids with autism who are grieving called Finding Your Own Way to Grieve. If you want to know more about the books too, that information is on my website. And they're at Amazon and Barnes & Noble, all the places where you can get books. But This is something I'm really passionate about. This film, I appreciate it so much. I saw a question that said, can we purchase the film? And I was going to actually ask that too. When can we get this thing so we can own it and I can share it with more people? Hopefully it'll be coming out on DVD soon or streaming on Netflix, because so many people need to know this information. And I totally agree with Drew about we need to have more conversations. I say I'm a grief activist, and an activist is a person who wants to change consciousness or give people new information about something. And that's what we need to do, because this is activism and we need to help people to understand a different way of looking at things. And we can only really do that through conversation and not fighting, like you said. And the more we feel comfortable talking about this, the more people hear about it, and it's so very important. So I really appreciate the Medicating Normal team and all of y'all, and I'm so happy to be part of these discussions.
Thank you so much, Carla. So I'll just close out and hopefully answer some of the questions about the film. We have a YouTube channel with over 100 outtakes from the film, which are shareable, and panel discussions like this one that we've recorded are also there on our YouTube channel for you to watch and share. If you know of or are affiliated with any conferences, mental health agencies, universities, or groups that want to host a screening, you can contact us at medicatingnormal@gmail.com. We did just sign with an educational distributor. So educational groups and like medical schools and things can purchase the film to show in screenings like this one. So we're in that screening phase currently, but down the line in a matter of months, we will be selling the film more affordable, like where you can stream a single link from Amazon. So that's coming. The film is on Facebook, Instagram, YouTube, and Twitter. So you can follow us and subscribe at all those social media platforms. You can also go to medicatingnormal.com and sign up for our newsletter. And we have resources listed on our website as well. If you have seen this today and you feel compelled to support the film, we also have a donate button on our website. And we can be contacted at medicatingnormal@gmail.com. We also have more screenings coming up soon, which you can find on our website under the watch button. And I just want to say thank you to all of our panelists today and all of our audience. Thank you for coming. We appreciate your interest in the film and your support. So thanks, everybody. And I think we'll say goodbye. Carla.
Thank you.
Dr. Drew, good
Thanks,
meeting.
everyone.
Nice to meet y'all.